And then let me set it up for Facebook. Got it in Facebook. Or maybe it just does YouTube. Okay. Only lets me do one at a time. Yes. Okay. So we're live for Facebook. Let me close that. Good. And then I'll just monitor questions that come in. So I'll just sprinkle those in as they pop up. Great. All right. So we'll get started. Welcome, everyone. This is the Sweat Fearlessly podcast. I'm the host, Alexis Reed. Our guest today is Dr. Tiffany Tate. She is a published author from Compton, California, and a graduate of UC Santa Barbara, where she earned her Bachelor of Science degree in Cellular and Developmental Biology with a Black Studies minor. After earning her medical doctorate degree from Meharry Medical College and completing her OBGYN internship at Naval Medical Center, San Diego, she went on to serve as a general medical officer for the Seabees. She served during Operation Enduring Freedom and the global war on terrorism. Dr. Moore completed her obstetrics and gynecology residency at Vanderbilt University Medical Center in Nashville, Tennessee, and practiced for 20 years before sustaining a hand injury that led to her medical retirement. Her life experiences, including those she shared with her friends, have overflowed into two books, Flow-a-Tree and Bad Touching. She has another children's book to be released later this year titled Little Engine Mia Sings, and this book will help children address bullying. So welcome, Dr. Moore, to the podcast.
Thank you for having me. Thank you very much.
So
I currently teach residents, family practice and OBGYN residents about women's health issues. So I enjoy talking to you guys today about fibroids.
Great. So I've had a lot of conversations with people about this topic, and in full transparency to everyone who's watching, listening, I was diagnosed with having fibroids. And it helped explain a lot of issues I'd been having. And I was a little upset it took this long to get diagnosed. And once I started talking to people, I realized how many of my friends and family had gone through similar experiences. And I felt like it was important to share, my experience, but also talk with experts about their experience and working with patients with fibroids and, sort of what you can look out for in that type of thing. So we'll start this conversation so that everybody is working with the same knowledge base. And if you could share with us, what are fibroids?
Well, fibroids are benign, non-cancerous growths in the pelvis. And basically, they come from the musculature of the uterus. And they can be problematic because they can cause symptoms. Now, the majority of the time, they don't cause symptoms. But when they do, they can essentially be a bugaboo to women because they can cause pelvic pressure, they can cause pelvic pain, they can cause urinary symptoms, they can cause bowel problems, but they are essentially benign growths that can just cause problems for women.
So what are some common symptoms the average woman walking around might experience that may make her want to get checked out for fibroids?
If you're having pain with intercourse, if you're having urinary frequency, if you're having constipation, or if you're having pelvic pressure, if you're having heavy bleeding, sometimes even irregular vaginal bleeding, those are signs that you should probably go see your primary care doctor, your gynecologist, or whatever provider you see, whether it's a physician assistant, nurse practitioner, whoever renders your care, you want to go see your provider and be evaluated because that's not normal. Usually you want to have a cycle once a month, but if you notice that your cycles are becoming more frequent, and on average, you should have a cycle that lasts about 4 to 7 days. If you notice that your cycle is lasting more than that, it's lasting 8 days, 10 days, 12, 15 days, that's not normal. And on average, you should be changing your pad every couple of hours. If you notice that you're going through a pad or a tampon every hour or more frequent than that, again, that's not normal. So if things start happening and you notice that you're passing large clots, that's not normal. So those are signs that you should go and see a provider for.
What is the process for getting checked out for fibroids?
Usually you want to be evaluated with a pelvic exam because you might notice that your stomach is feeling a little bit more bloated, and people might say, oh, are you gaining weight? You might look a little distended. Some people might remark, are you pregnant? No, you're not. It's your uterus and it's growing, and it might look as if it's larger than larger than normal. And your uterus is growing and it's nodular. So you want to be evaluated. And usually when a doctor or your provider is doing what's called the bimanual exam, and that's when they stick one hand on your abdomen and stick one hand in the vagina, and they feel the uterus kind of like this, and they want to get an idea of the contour and the shape and the size, and they can feel how your uterus is actually feeling between your hand, and they can feel some of the nodularity. They can get appreciation for the normal shape or the abnormal shape of your uterus. And then once they do that, they can decide whether or not they want to order an ultrasound.
And can you talk about the ultrasounds that people might receive, of what that I know what my experience was, but for folks out there, what kind of ultrasound they might have and what that experience is like?
Yes, usually the first step is going to be an abdominal ultrasound. And that's when they stick a probe on top of the abdomen. And then they might proceed with a transvaginal ultrasound. And that's when the probe goes into the vagina, and then they look that way. And sometimes they want to stick fluid into the uterine cavity and do sonohistograms to get an idea for the internal shape, to see if there's distortion within the cavity. And sometimes they may want to get an MRI, and they will talk to you about what other imaging they might need. But usually the gold standard and the first step is a traditional ultrasound, and then they will proceed with more invasive things after that.
So what are they looking for when they're doing these ultrasounds?
They're looking for abnormalities in the abnormal shape, because usually the uterus is small, about the size of the fist. And if they're looking for any abnormal outgrowths from that small normal shape and size, and if they see anything abnormal, then they will call you and they will come up and they will talk to you about what your plans are. And based on your age and your future fertility options and desires, they will come up with a management plan, because you are still always in control. No provider is going to dictate to you what you do with your body.
That's a good comment to share, because I think sometimes people feel like, okay, I don't have any other options, or I'm just going to do what I'm told, but maybe their gut is telling them maybe you should just do a little bit more research. I know that the first option that was offered to me was a hysterectomy, and I was like, oh, I don't know about that. That's a little scary for me at this age. And so it's good to know that you have options.
Yeah, unless you're hemorrhaging and your life is on the line, I don't think hysterectomy is the first choice. And even if you're hemorrhaging, sometimes we can still go with medication to stabilize you. Because when you talk about treatment options, there's expectant management, there's medical management, then there's interventional radiology management, and then there are different surgical options. And when you talk about surgical options, you have minimally invasive surgical options all the way to hysterectomy. So when I was actively practicing, I always talked to my patients about, okay, how aggressive do you want to be? Because there are different grades of surgery. And depending on the size of your uterus, we can talk about what's reasonable and what's not reasonable. If you have a fibroid that's maybe 5 centimeters or less, we can probably do some minor surgery and we can get away with keeping your uterus and being okay. But if you have a 20-week size uterus, okay, maybe we cannot get away with some minor surgery. We need to be a little bit more aggressive because we have some aggressive fibroids because, we have like a 5-week size uterus. A 5-month size uterus working against us here. And it depends on what your hemoglobin is, because if you're hemorrhaging to the point where you're anemic and we're having to transfuse you on a regular basis, your life is on the line. You're dizzy, you're lightheaded, you're having chest pain, you're getting short of breath. We're working against some different odds here. So the way I counsel you is going to be different than the way I counsel someone who has smaller fibroids.
And so can you share a little bit about, what people might experience? Because I guess some people have maybe one fibroid. Some people I've seen where they've had 40 fibroids. Can you share sort of the range and the sizes that you've seen in your experience?
Yes, yes, I have. I have seen people who have had mild fibroids and they can get away with what's called wearing an IUD, an intrauterine device, which is a Mirena IUD, which is where you can stick a progesterone secreting IUD inside the uterus and it just secretes progesterone into the lining of the uterus, and that controls their bleeding. And sometimes their periods go away. And that's good for up to 5 years. And they're good until they're ready to have kids. And maybe in 2 to 3 years, you pull that out, they get pregnant, they're good to go. They do that a couple of times. And when they're ready to have more babies, we repeat that cycle for a few years. And they don't even have to need a hysterectomy. And then say later on, we do what's called an endometrial ablation, where we burn the lining of the uterus. And that kind of tamponades that lining, and their periods either go away altogether or they're significantly lighter. And then when menopause comes, they walk over, they jump the broom, they marry menopause, and they walk off into the sunset and they're happy. Then I've seen women who have had that 5-month size uterus, they've come in, they've needed blood transfusions because they failed the myomectomy. Because when you do a myomectomy, there's about a 25% chance of a recurrence. And so they weren't part of that, but there's a 75% chance that you're going to be fine. So they weren't part of that 75% that did great with their myomectomy. They were part of that 25% where they came back. And then they needed to have the hysterectomy. And then they had their hysterectomy, and then they were great. And they were like, oh my God, I just wish I had the hysterectomy from the beginning. And so it just depends on where you fall on the spectrum. It just depends on where you go. It depends on your future fertility. If you really want to have a child, keep your uterus. But say if you have 5 kids at home and you know you're done, the uterus is the only organ that we do not transplant at this time. We donate kidneys, we donate hearts. We do not donate a uterus at this time. So when you are finished using it, and if it is causing you that much trouble, get it out of there. And so you know what you need. And you can keep your ovaries, they're giving you hormones, but if you're done having children and your uterus is causing you problems, pray about it, give it over to Jesus, and give it over to pathology. That's my perspective. Because once you're through with it, you don't need it anymore.
So some people might get a partial hysterectomy then, where they would keep the ovaries and can you just explain a little bit about what the
Yeah.
different hysterectomy options are? Because I know some people get partial hysterectomies.
Yes, there are so many options. If you don't have problems with your ovaries and your ovaries are still working, and you're in your 20s and your 30s and your ovaries are still functional and you don't have any issues with them, you can by all means keep them. No doctor is going to want to take your ovaries if you're young and they're functional. And even if you're less than 45, most doctors will want you to keep your ovaries. If you're over 45, you can have that conversation with your doctor about whether or not to keep your ovaries. It's debatable, but I would say if they're still functioning, they're still working, you can keep them. So you can have what's called just a hysterectomy, where hysterectomy is just removal of the uterus. What's called a bilateral salpingo-oophorectomy is where they remove both of your tubes and your ovaries. Salpingo are the fallopian tubes. Oophorectomy are your ovaries. So some people who have problems with their tubes and ovaries will have those removed and they'll keep their uterus. So if they have problems with cysts or recurrent cysts or things like that, or if they have an ectopic pregnancy, which is a pregnancy in their fallopian tube or in their ovary sometimes, and it ruptures or something, they'll lose their fallopian tube. And so sometimes they lose their fallopian tube and they still have their ovary. So they say, oh, I had a salpingectomy, or I had this. That's where that comes from. And so you have different pieces of your body that can be removed, but you'll have different other parts that stay. So you can keep your ovary or you can keep your tubes depending on what's going on. And if you wanted to keep your ovaries, you can have your uterus removed. Some people who want to keep their cervix have what's called a supracervical hysterectomy, and that's done laparoscopically, where they truncate the uterus above the cervix, and then they use what's called a morcellator. Think of it like a Pac-Man machine, and they chomp it up and they remove the uterus in pieces. Depending on how big your fibroids are, they can possibly do that, but your uterus cannot be too big. What sometimes they do is what's called a mini lap, where they cut an incision maybe about this big and they can take it out in smaller pieces. Sometimes they do what's called a laparoscopic assisted vaginal hysterectomy. They don't leave your cervix, because if they're taking it out through the vagina, that means they have to take your cervix because it's coming out through the vagina. And that means you do not have an incision. But when you have a laparoscopic assisted vaginal hysterectomy, a lot of times you get to go home the same day. Your recovery is less painful. You still need time off because you just don't have an incision on the outside. You still have those incisions on the inside. You can sometimes still keep your ovaries, but again, you still need to recover on the inside. And you can have your ovaries removed as well. I would say it depends on the skills of the surgeon. I would talk to the surgeon, make sure they feel comfortable with laparoscopy, and make sure they feel comfortable with laparoscopic assisted vaginal hysterectomy, whatever it is you decide you want to go with, if you were going that way, whether it's a laparoscopic assisted vaginal hysterectomy, laparoscopic supracervical hysterectomy. Whatever you want to do, make sure your surgeon feels comfortable doing. And depending on the size of your uterus, they may say, oh, your uterus is too big. We need to do what's called a laparotomy, which means they want to cut you open. If you have a 25 or a 30-week size uterus, then you need to be cut open, because that's like the size of a baby. And you don't want that to come out vaginally, because you don't want everything falling out. When you sneeze and, you pee on yourself, that just stretches everything out. That's like delivering a baby down below. So you don't want to have to go through all of that. Yeah, that's no fun at all. No bueno. So you want to go with what the doctor recommends because they want to do what's in your best interest. So they will usually counsel you. And you can always get a second opinion. Doctors don't usually get offended for you to get a second opinion. They want you to feel comfortable with whatever decision you're making.
And I think that's good to know because I think some people might think, well, if I get a second opinion, my doctor is going to think I don't trust them, or, and there's this sort of loyalty that I guess people have, but it's your body, as you said, it's your body, right? And you can make the decisions for yourself. So I think that's helpful to know. So you talked about your uterus being different sizes, basically growing because of the fibroids. Do they go back? Do they get smaller once the fibroids are removed?
As long as they take out the core and they get all of the fibroids, they should. And a lot of times they will also give you medication to help shrink the fibroids. Sometimes they will give you medication before surgery, and sometimes they'll give you medication after. And the doctors will talk to you about that. And hopefully they will go back to normal. Your uterus will go back to normal, and you will not be part of that 25% where they recur. Because again, 75% of patients do great with myomectomy. So the odds are ever in your favor that you're going to do fine. So 75% is greater than the 25%. So there's a 3/4 chance that you're going to do great. Okay. So the majority of the time, patients do great with myomectomy.
Can you describe what a myomectomy is versus a hysterectomy for people who maybe aren't familiar with that term and the different kinds, because you mentioned a mini lap and some different things.
Okay, so imagine this is your uterus, and this is, I don't know if you can see this, I'll get closer. So a myomectomy is, my fist is the uterus, and this is the little growth. A myomectomy is when they just come and just cut this little piece off. So that's a myomectomy. So they just kind of take that little piece off. So a hysterectomy is when they come in and they take this whole piece off. So they're going to take the whole muscle. So the myomectomy is just when they go in and they just remove a piece of the uterus. They remove the abnormal piece. And again, myomectomy is just an abnormal growth of the muscle. It's not cancer. It's just an extra piece of muscle, and it's benign most of the time. Because I don't want to get into leiomyomas and leiomyosarcomas, whole different discussion. But we don't want to go that route. But we're talking about benign growth fibroids. And so basically, so the myomectomy is when they just go in and they remove that extra piece of tissue. And usually it's from the outside. And if they go inside with a hysteroscopy, like if they go in through the vagina and they stick the camera in, and they can do it through the vagina as well. They can shave it down if they go in with a camera, with what's called a hysteroscope. So they can go in through the abdomen and do it this way, through laparoscopically. If they go in through the belly, like they can go through the belly button and through different ports, or they can go in this way and shave it down. They can use what's called a resectoscope. Think of it as like a little Pac-Man machine, and it'll chomp it down until the inside of the uterus is smooth. So if there was something hanging in this way, they would shave it until that cavity was nice and smooth again. And so, but again, hysterectomy is when they remove that whole muscle. Now, when we talk about with hysterectomies, they can do the laparoscopy where they go in through the belly button and they'll have an incision, maybe about the size of the tip of my finger. And usually they have like, different ports, usually 3 ports. They'll go in through the belly button, and then they'll have a port to the left and to the right, and sometimes one right above the bladder area, suprapubic. Okay. Now, a lot of times when they do a laparotomy, think of it like a C-section scar. And they cut kind of right there, a little transverse incision. And sometimes if your uterus is really big, they'll do a vertical scar up and down. Okay. So you can have this little bitty one for laparoscopy, or you can have a big smiley face or a big up and down scar. So it just kind of depends on what the doctor recommends. Now, a mini lap is going to be a fraction of that incision. So it's a minimum of the scars. That's why it's called mini.
Got it. That's really helpful. So I think earlier you touched on this issue that a lot of women have with having a hysterectomy or considering one, which is, oh, my hormones, how's that going to impact my hormones? And I've read about this, but I think maybe some other folks would be curious. Do fibroids impact your hormones?
Fibroids by themselves do not impact your hormones because your ovaries make your hormones. Now, fibroids are impacted by hormones a lot of times, and that's why they will treat fibroids with different hormone medications to help stunt their growth. And they can give you different medications to shrink them. And they can give you Lupron and with or without add back therapy. And that's depending on how long you're going to take it. A lot of times, if they give it to you for 6 months or a year, they'll give it to you with the add back therapy because it can send you into like a premature menopause with the hot flashes and the night sweats and all that not fun stuff. And so, but it will shrink the fibroids, but it will stop the bleeding, it'll shrink the fibroids, but it will make you a miserable person and you won't want to be around other people. It might not make you very nice. And so we usually want to give you some add back therapy just to make you a little bit of a happier camper.
That makes sense. Now, would you typically recommend that for somebody with smaller fibroids?
It depends on their symptoms. I prefer to treat the patient and make sure that they are happy with their symptoms. So if their symptoms are really bad and they're having issues with the anemia, and I would have a conversation because I don't want to treat the fibroid, I want to treat the patient.
Got it. All right. So, okay. So you've talked about fibroids, and I understand there's different types of fibroids. Can you talk a little bit about or share a little bit about different types of fibroids somebody might have, and what do they look like?
Well, the types are based on the location and within the wall of the uterus. And so, like I was telling you, you have this wall, and if you see my hand, and if you see my fingers, you have fibroids within the cavity, then you have fibroids distinctly within the wall, and then you have fibroids on the outside of the uterus, kind of sticking within the abdominal cavity. And so you have like submucosal fibroids with inside the uterus. And then you have the ones within the wall called intramuscular, and then you have the pedunculated fibroids that are sticking on the outside of the cavity that'll just kind of hang out this way. So you have the submucosal, intramuscular, and then you have the pedunculated ones. And they can range in various sizes and they can grow to various sizes. And it's nothing that you have done. And the risk factors for fibroids, they vary. Unfortunately, a lot of times it can be genetic. And there's nothing you can do. We don't pick our families. We don't pick our genes. We don't pick our race. It's just kind of the luck of the draw.
And I'm glad you mentioned that because there's a lot of my friends that I've talked to about this have been Black women. So I'm curious what the what the demographic data show about who tends to, or if there's a tendency in one community or another to have fibroids.
I'm glad you brought that up because it is real. Statistics show that Black women are 2 to 3 times more likely to have fibroids as opposed to white women. Why at the present time, we don't know, because we don't have the research right now. We're starting to get that and get funding for that because there's a lot of systemic issues there. But that is one of the realities of where we are. And another reality is that we don't see that change within the Asian and Latino community. Another sad reality is that within the African American community, the disease is likely to be more severe. And there's a lot of socioeconomic and racial disparity issues attributed to that. And the anemia is likely to be more prevalent. And that also has to deal with historical issues of being neglected within the medical community. But again, something that we're trying to be aware of, more cognizant of, and trying to work on.
Yeah, I'm thank you for sharing that. I know a lot of people, a lot of friends I talk to, family members, we talk about this issue of not feeling heard or seen. And, I've been saying I'm having this issue and the doctor's not believing me. And then we see stories about even professional athletes who, have a lot of resources and they're in the best shape of their lives or in the best shape of anyone on the planet. And even they struggle with some of these issues.
I would recommend to even physicians, we have the same problem. I would recommend when you go to the doctor for any patient, regardless of your age, race, color, creed, be your own advocate, especially now, especially in this post-COVID climate, because when you go to the doctor, a lot of times they're afraid to touch you and they're trying to get you in and out. Be your own advocate, demand to be heard, demand to be seen, and make sure your needs are met. Do not leave until your needs are met. Make sure the nurse hears you, make sure the physician hears you, because it is very important. You are paying for a service and you want to make sure that you get what you pay for.
That's really great advice. Be your own advocate. I made a note, which is really, really great advice. And hopefully the folks that are listening now or later will take that to heart. Why is it not part of a regular screening process, fibroids?
Well, when you go in for your annual exam, or now it's like, I think every 2 years exam, when you have your bimanual exam, that is the screening process. When they do the pelvic exam, because they're checking to see the size of your uterus when they do the bimanual exam. When they fill your uterus, they're checking for any nodularity. They're checking to make sure your uterus is the right shape, right size, right contour. If they feel anything unusual or feel any abnormal growths, then they will send you for further screening. So when they do the bimanual exam, that is your screening exam. So that's why I said it's important for them to do that exam. So a lot of times when they say, do you want to get undressed or do you want to decline your pelvic exam? Don't decline it, because some women will be like, oh, no, thank you, I don't need it. No, you need it. Don't let them get away with saying, oh, I'm going to skip my pelvic exam, because sometimes they will offer that to you like they're trying to help you out. like they're trying to hook you up, but it's not hooking you up. It's not helping you. It is doing a disservice. And I think it is important for you to recognize that, for you to realize that and say, no, I want my bimanual exam. I need my bimanual exam. I know it's uncomfortable. Nobody wants to have two fingers in their vagina. Nobody's like me, because I hate getting it done too. But I know the importance. I recognize the importance of it. And it is something that you need to have done. And even when they stick the rectal, their digital rectal exam, because they're feeling for any nodularities in there, sometimes, for endometriosis and things like that. All of those things are very uncomfortable, but they're necessary. Putting their hands on your body, listening to your lungs, all those things are necessary parts of the physical exam. And they can't get away with not doing those things because you need them.
And even if they do them, they can still miss it, right? If you're feeling certain symptoms and it's possible that they could miss it during the exam, right? I had my exam and I said, I've been having all of these issues. I've been bringing them up for years and something just doesn't feel right. And they got the exam and it was, this is really bad. So maybe it's possible to miss it, right? Even just with that exam.
It is possible to miss it. And that's why you have to complain. When they ask you, how are you doing? A lot of times we'll say fine when we're not fine. When they ask you how you're doing, that's kind of like your review of systems. Back in the day when we did exams, we used to actually go through the review of systems. We would say, okay, how are your eyes, your ears, your stomachs, your urinary systems? Is your bleeding okay? Are you breathing okay? How's your heart? We would actually go through each system. But as managed care has taken over, we've summed it up into how are you doing? And that's our review of systems now, because they've limited the time with each patient to only so much time. So if you go in and the nurse says, how are you doing? And the doctor says, how are you doing? They don't really mean, how's your day going? They really mean, are you having any problems? So they want you to say, I'm having a problem with this, or I'm having a problem with that. That is your time to say, doctor, I have this problem. If you don't tell them that you're having a problem, they won't know to really focus in on that. And that's what I mean, be your own advocate. So if you don't tell them you're having a problem, they won't be able to focus in on that. So if you go in for a checkup and you're having an earache, he's just going to listen to your heart and lungs and get you out. He's not even going to look in your ear. But if you say, hey, my ear is hurting, he's going to take out his otoscope and look in your ear. If you say, oh, my tummy is hurting, he'll just listen to your heart and lungs. He's not going to feel your abdomen. Or if you say, oh, well, my leg is hurting, okay, he's going to stop and he's going to check your leg. He might even measure it. Oh, I should probably send her for an ultrasound to make sure she doesn't have a clot. Oh, you just traveled to Australia. You're at risk for a DVT. So those are things that are going to trigger the doctor or your nurse practitioner or whoever you see to do a little bit more than that routine. So when I say be your own advocate, you have to bring these problems to that provider's attention. Oh, I bled through 3 pads in an hour. Oh, okay. You're here for a physical. I want you to get undressed. I need to check. Maybe you have a polyp. Maybe you have something else going on. You're here for this, but I want to check something else too, because now you're letting me know more is going on. Oh, you have some back pain. Oh, okay. Now you're having some urinary frequency, you're having some constipation, and you're having some pelvic pressure. You're having some pelvic pain. Oh, you're having pain with intercourse. Okay, I'm thinking a few more things now. So, but you just told me everything was fine. You came here, you said you're okay. It doesn't sound like you're okay. Yeah, you're kind of, I mean, you're okay overall, but you have some issues that we need to address. So let's work this out. Let's address these.
Yeah. I had a friend who gave the advice that, just put in your phone, in your notes app or whatever app you use, when you have an appointment coming up or just in general, you're going about your day and you're like, there's this nagging issue that I have. Make a note so you don't forget when you're at the doctor's office to tell them these things, because like you said, they can't read your mind and they don't know what you're experiencing if you don't tell them.
And then when you get home, you be like, I should have said, I should have did. And then you send an email and then you go back and forth. And then the nurse is responding, but the nurse isn't the doctor. So you don't get the attention. And then you get frustrated. The nurse gets frustrated. The doctor gets frustrated. Then you have to pay another copay. And then you get frustrated. And you're like, man, I'm wasting my money. And so, I mean, you're all people trying to do the best you can. The doctor wants to meet your need. You want your need met. The nurse wants to meet your need, but you guys aren't communicating well. So I would say I recommend in your memo section, start, okay, at my appointment, bring up this. At my appointment, bring up this. But then at your appointment, you got to remember to look in that.
Right. Right. Okay. So getting back to the fibroids. So, I guess the first question I have, or the next question I have is, let's say somebody doesn't want to get them removed. What are some of the things that could potentially happen? Will it stop growing? Will they keep growing? What could potentially happen?
Well, watchful waiting is fine as long as their symptoms are mild. There's nothing wrong with watchful waiting and expected management. I think that is reasonable because it depends on what their symptoms are doing. And if their symptoms are tolerable, I think it's okay. If they are okay with waiting with my patients, I've always been okay with waiting. And it depends on their age. They can wait until they go into menopause. And if they're doing okay, I think it's fine. And I think it's reasonable. A lot of times you can do medical management. Some patients have been managed with birth control pills, and that has been fine, and they've done fine. They weren't ready to get pregnant anyway. And so the only issue was when they came off of birth control pills, how heavy was their bleeding and was it manageable? And did they have anemia? Was the anemia symptomatic? Were we able to control their anemia with iron supplementation? And it's just a matter of, okay, is it reasonable? Is it okay? It's all about communicating with your provider and making sure you are good with the management. And as long as you are good with it, remember, this is your body. Nobody is going to force you to do anything you do not want to do.
So let's say you decide to go forward with surgery, and you've explained the surgery to us now. What happens next? How do your patients tend to react or respond to surgery?
Most patients do really well with surgery. I say you have somebody take you to surgery, you get your medications before surgery, because the last thing you want to do, if possible, is have to go to pharmacy after. So most of the doctors, if they're nice and kind, they will let you pick up your prescriptions before surgery, or they'll give it to you the day of surgery and let whoever's with you pick it up that day, so that right after you get released, you can go home and relax and take care of it. They'll give you your off work order and you do pretty well. You'll be on pelvic rest. They'll give you your off work order, and depending on how they plan to do it, whether it's laparoscopic or through a mini lap incision, that will determine if you're going to be off, 2 weeks, 4 weeks, or 6 weeks, depending on the size of the fibroids and the route and the size of the incision. And as long as you follow your doctor's orders and do limited activity, you should be fine and you should do well. They usually counsel you on minimum blood loss. A lot of times they will inject a little bit of vasopressin or something into it to minimize the amount of blood loss at the time of the surgery into the fibroid. And I think the surgery itself usually goes smoothly.
So you've mentioned that, you're cutting into a muscle. What is that sort of, let me back up. A lot of people, they'll have a C-section and you hear these horror stories about, what happens to them after with their skin or their muscles. What would be your advice to someone who's just coming out of surgery, how they should recover?
I would say get some Mederma scar cream. Yeah, that way, if you're concerned about your scar, no matter the size of the scar, and some Vaseline. That really helps with the elasticity of the skin, in my opinion, because I had 6 surgeries after my fall, and that really helped with my scars. My surgeons were all impressed with my healing. So I think that that really helps. But I believe that as long as you follow your surgeon's orders and you don't try to overdo it, because a lot of times people are like, well, I know that's what he said, but I think as long as you actually rest, and I would say let people do for you. A lot of times we think, I can do it. I'll do it myself. No, this is the one time that you should be treated like the Queen of Sheba. And so whenever people want to do for you, let them, because eventually they're going to stop and you're going to wish that they were still doing for you. So I would say, please let the people do for you and take all the love and support that you can get at this moment. Welcome it. If somebody wants to cook for you, let them. If somebody wants to clean for you, let them, because again, it is going to stop.
So typically you wouldn't lift heavy things, right? And exercise, heavy exercise is probably out of the question. I know a lot of times people have procedures and they're told not to have intercourse. I would assume that's the case for a certain time period with this surgery, right?
Yes, it depends on the route and everything that they're going to do. So based on what the surgeon plan is and the route of the surgery, usually they put you on pelvic rest for anywhere from about a few weeks to a month, sometimes 6 weeks. It depends on the route of the surgery and how extensive the surgery is.
After you've had the surgery, do people tend to have regular bleeding? Do they, does it take longer or does it come sooner to get their period? Um, how does that play out?
Well, you're going to have some spotting, and depends on if he's going to put you on any medication after surgery. Sometimes you'll fall back into your normal cycle, and it depends on where you are in your cycle. And so everything is relative, but you can expect some bleeding after the surgery, especially because you've been under some stress. But it depends on where you are in your cycle and whether or not he's going to put you on medication. So everything is, I know I sound like a politician. It's all relative, but it really is relative. It depends on whether or not he's going to put you on medication or not.
And so what is the typical recovery time, like full recovery? Maybe you've stopped spotting or you're not feeling as much pain, you can return to your regular activity. How long does that typically take?
I believe you should probably feel great within 4 to 6 weeks.
What are some misconceptions people have about fibroids?
I believe a lot of times people worry that they are people think that it's going to kill them. And unless it's a leiomyosarcoma, which is the malignant form, you should be okay. And that's the major issue. With fibroids, most of the time they're benign. And that's the good thing. It's not the malignant form. And that's a blessing. And I thank God for that.
Great. So is there anything else you'd like to share about fibroids, hysterectomies, anything else related to this topic?
I believe that women should feel empowered and know that no matter what decision they make, they have control over their bodies. No provider is going to ever force them to do anything. And they should not be afraid to talk to other providers, because getting a second opinion is not ever going to be a bad idea. So I want to reinforce that, because when you go to your doctor, you should feel confident in the decision that you made, because once we take out your uterus, we're not putting it back. And so you need to feel comfortable and 100% confident in the decision that you make.
So now shifting gears back to you and your experience, what got you into this field originally?
Well, I love delivering babies. I think delivering babies is the best job on earth, which is why I was so sad when I had to stop. But also, I love women's health. And I think being able to help a woman and alleviate her pain and help her feel better is significant. And being able to take her to the operating room or do a procedure and help her realize that she is in charge of her health is pretty significant. And I love just the outreach that I get to do in the community.
Can you share a little bit about the books that you've written and what you're doing now that you've transitioned in your career?
Absolutely. Floetry, my first book, I call it my third child, my third baby. It is a book called Life, Love, Floetry, Life, Love, and Liturgical Issues. And it is the book that kind of helped me transition from not being able to work, because it was a book that I wrote because I needed to write myself out of a depression. And it was really hard not being able to practice medicine anymore. And it was something that I wrote as I felt I needed to find myself, because I had lost my career and I didn't really know who I was. So I started writing poems in the memo section of my iPhone. And I read some of them to my friends, and COVID had just hit. And they were like, "Oh, you should publish this." And I was like, "Nope." And they're like, "No, Tiffany, really, you should publish." And I was like, "No." And I felt convicted by God. And I gave it to two publishers, and they were like, "Yeah, you should publish this." And two publishers wanted to publish it. And I was like, "Oh, I guess I should publish it." And so I went ahead and I published it. And that was my first book. Bad Touching is the story of two little sisters who are essentially touched inappropriately by their mother's boyfriend, and they don't know what to do. And this story teaches children how to identify with and report being abused. And I think this resonates with children because this came out, and I think the young boy had just been assaulted essentially by the Dalai Lama. I don't know if you saw that. And the Dalai Lama had asked him to suck his tongue. And I think it's important for children to recognize boundaries and to know who to trust and who not to trust and how to report those things. And since then, one of my sorority sisters has given this book to one of her friends, and her friend's son came to her and essentially reported abuse. So the book is doing what it's supposed to do. It is a catalyst for helping children come forward and protect themselves. And basically, it's my story. It's what happened to me as a child. And so I just want to make the world a better place. Now, the next book is Little Engine Mia Sings. It's about a little choo-choo train who loves to sing, who gets bullied on the playground. And this is the story about how children can come together and support one another and combat bullying, and to let each other know that it's not appropriate to tease each other to the point where they make each other feel intensely bad or sad, and that they can correct one another in an appropriate way. And so my goal is to make the world a better place, one book at a time. So
That's great. And thank you. Thank you for that service that you're doing. I think, especially with the bad touching book, that sounds like it's already impacting people in a positive way. What's next for you?
actually, I'm actually in the Carla Hall cooking contest. I'm in the quarterfinals.
Oh, congratulations. You know, it's funny. I went to go get my ultrasound, and Carla Hall lives in our area, and she crossed the street in front of me as I'm getting ready to pull into the doctor's office. So this is a full circle moment.
6 degrees of separation, right?
Yes. So tell us about that competition.
And so basically it's an online competition, and you have to vote. And if I win, I'll win cooking lessons from Carla. I'll be featured in her magazine, and I could potentially win $25,000. Now, when I was in middle school, I used to feed the homeless in the streets of LA. And that was the catalyst that made me want to become a physician. I would like to use that money to help feed the homeless. And I mean, it's kind of altruistic. So I'm like, dear God, please let me win. And so I feel like it's coming full circle because I'm already a physician, and I would really like to do that. So this is something near and dear to my heart, because I'm just a mom who loves to cook, and there's all these fancy chefs, and I'm still in the competition. And so I'm trying. And basically I just have, the things that I make, and I make pretty good food. I feed, sorority people, I feed fraternity. So I have different people voting for me. I feed people in my church. And so you look at the food that I've made, and you vote based on my dishes that I have online. And so I'm hoping that I can continue, and I'm praying that I win. I'm claiming it. And so I am still in the competition, and I'm going to continue to write my books. And again, like I said, my goal is to make the world better, one book at a time. And I have 2 more books that I've written that are going to be published probably either at the end of this year or next year. One is called Money Matters, and the other one is called Perfectly Perfect. And Money Matters is to teach children about investing and tithing. And Perfectly Perfect is to teach children about body image and eating healthy, because I think that that is important.
It sounds like maybe once those books are published, you'll have a cookbook. How can how can we support you?
You can find me on Instagram at Dr. Tiffany, Tiffanie, Tate, Tate, Moore, Moore. You can find my books on Amazon or Barnes and Nobles at Dr. Tiffany, Tiffanie, Tate, Tate.
Great. And are you going to share a link with me so we can vote for you in the cooking competition?
Absolutely. That would be great. Let me pull that up.
And I'll make sure I put all of this information in the show notes for those of you listening. If you're not listening live, but you're catching this later, they should be in the show notes when you listen to this later on. And so we'll have the Instagram information, Amazon, Barnes and Noble, and the Carla Hall cooking competition. And now I want to go see what your recipes are.
Awesome. It is HTTPS, the little colon,
Mm-hmm.
2// fave, FAV, chef, CHEF.com /2023 / Tiffany, TIFFANIE -Tate, TATE.
All right. And I'm just going to plug this in real quick and then share the link in the chat box on YouTube Live. So bear with me a moment. I'll edit this part out when I publish it to Spotify and Apple Podcasts and everywhere else. But I just want to make sure I have the link, and here it is. And or I put it in wrong. Looks like I can buy that link, so I know I put that in wrong.
I was gonna see if I can try to put it in the chat box.
Yes, that would be great. And then I can just copy and paste it. Yeah, that's really exciting though. And it sounds like you just have a lot going on. You're really active in giving back and being involved.
Yeah, that's what my aunt says. She's like, "You're very busy." Yeah, I also wrote a play for my church.
Oh, wow.
And so she's like, "You're just always doing something." I said, "Yeah, I like to do stuff."
Now,
I-
are you still practicing physician?
No, they retired me because I can't bend my right hand. So let's see. Okay. Okay, here I'm putting it in now. Let's see.
All right.
No, they retired me. When I fell out of the trailer, I lost. See, I can't bend it. That's right there. That's as much as I can bend that.
Mm,
I can bend this one.
yeah.
I can bend that
Oh,
one.
wow.
So you can't be a right-handed surgeon without a right hand.
Yeah. Yeah. Well, I'm sorry that that retired you, but I'm glad that you're still able to make an impact. Um, and so thank you. Thank you for your service to our country. And thank you for everything you're doing to keep women and children educated on health topics, social topics. Thank you.
I just said plot twist.
Oh, you're currently in first place. That's great. And there's only 4 days left. So I'm putting that in
Well,
on
I'm in first place till Thursday. There's still 500 people in the competition. So, and there's 10 categories or 10 groups. And so the competition goes until like mid-August. And so there used to be like thousands and thousands, I guess tens of thousands. So
wow.
I'm just like, okay, I'm still in it.
Well, I joked that while I'm recovering from surgery, I'm just going to be doing food blogging, and because I can't do all my fitness stuff. But maybe I'll just pick some of your recipes to make, and I'll let you know how it goes.
Hey, you let me know. I'll send you a couple.
Is there
You might like my egg rolls. It's really easy. I made some shrimp and spinach egg rolls.
Mm,
Or
okay,
lobster and spinach egg rolls. They're both good.
that sounds good. Is there anything else you'd like to share before we wrap up?
But I am just very thankful for this opportunity. And anytime you want to have me to talk about women's issues, I'm available.
Great. Well, thank you so much for your time and sharing your knowledge with everyone. And to all the listeners, thank you for checking out this episode. Be sure to check the show notes for more information. And until next time, everyone, be well. And I'm going to stop the recording.